Good morning. It is week 3, and we are talking aerobic adaptations today. Before we get into it, be ready. Just like I said, you're going to have a few quiz questions coming up any second right now, based on those 2 articles you were supposed to read. So, now, before we actually get into the presentation today, so I think this week is probably the last week, which is where the content is a little less relatable. It's a little less tangible for the average athlete. As a coach, we need to understand the elements of bioenergetics and what we utilize for energy. As a coach, we need to understand the physiological underpinnings of training and training adaptations. So I think I definitely understand that this material can be difficult. However, it is very important. I think after this week, we start to get into much more of the relatable material from a coaching and training perspective. So, last week. So, we need to understand that there's going to be both acute, right, which is that short term, right, that immediate response, and chronic adaptations at the cardiovascular, respiratory, metabolic, and muscular level, right? So we need to understand those differences. We start out today by talking about acute changes, specifically in the cardiovascular system with response to exercise. So think about it. What are some acute changes, right? Take a minute, think, pause the video if you can. What is an acute change in our cardiovascular response? What happens? Well, first thing, we're going to start to increase our blood. Our heart is going to pump more blood to the working muscles, right? So we're going to increase cardiac output, which is denoted by Q, right? Cardiac output is determined by stroke volume, the amount of blood pumped, and the frequency, heart rate, right? Heart rate is the frequency which with the heart contracts, right? So cardiac output equals stroke volume times heart rate. At the onset of exercise, there is going to be an acute increase in both stroke volume, and because stroke volume is increasing, cardiac output is going to increase. Stroke volume typically plateaus around 50% VO2 max, which is a relatively low exercise intensity. So how do we get the rest of the blood we need to our working muscles, right? If stroke volume plateaus and it's not going to increase much more once we get past 50% VO2 max, well, we clearly have another 50% of our VO2 max that we can exercise at. How do we get the rest of the blood to the working muscles? And the answer is the rest is from heart rate, right? So heart rate becomes the primary driver of cardiac output once we get above 50% VO2 max. And this makes sense. Think about it. If you guys start with a walk, right? Does your heart rate elevate tremendously? Not really. Maybe it'll go from 70 beats per minute, when you're at rest to 90 beats per minute. And then, maybe you go into a brisk walk and it'll go to 100 beats per minute. But they're not incredible increases. Now, as we start to actually go into a very light jog, maybe we start to get up to 50% VO2 max at a very light jog. So the primary driver up to that point is simply an increase in stroke volume. Once we get above that and we start to do a little bit more than a jog, like a hard jog, right? That's heart rate, where your heart rate is going to go from 120 to 150 to 155, and then we get into 80, 90% VO2 max, where your heart rate gets up to, 180. It approaches your near maximal levels, 185. That's the primary driver of cardiac output once we get to those exercise intensities. So, stroke volume mechanisms and determinants. So what really determines stroke volume? We just spoke about what determines cardiac output. What determines stroke volume? Your end diastolic volume, right? So your end diastolic volume, which is the volume left in your left ventricle specifically. We need to remember what the difference is between systole versus diastole. right? This comes into play when we start to talk about blood pressure later on today, where systole is ventricular contraction. So systole is that big number, right, on blood pressure, right? The 120 versus over 80, right? So systole is when our ventricles contract, and diastole is when our ventricles and our heart relaxes. Another thing that's going to help drive this stroke volume is an increase in catecholamine action from the sympathetic nervous system. Now, how do we assess stroke volume? Well, I shouldn't say assess, but how do we explain it? Well, the Frank-Starling mechanism is how we explain it. And you guys should remember this now from exercise physiology, where aerobic exercises increases the amount of circulating blood, which makes sense, right? And as blood circulates, or the increase in blood circulating, that's going to change our end diastolic volume, and it's going to go up, right? As your end diastolic volume, right? Your end diastolic volume is the blood in your left ventricle. As that increases, what happens? The left ventricle is going to stretch a little bit more. And we talked about this a little bit last week when we talked about your heart, and your heart, specifically your left ventricle, being the part of the heart that hypertrophies the most. Okay? So that left ventricle is going to preload and stretch, and this stretch, right, leads to a more forceful ejection from the heart. And that's one of the mechanisms behind an increase in blood pressure when we exercise. So, like I said, we're going on to blood pressure, where our normal blood pressure while we're resting is 120 over 80. As we exercise, systolic blood pressure will increase at the onset of exercise. So we need to know which blood pressure increases, what decreases, and it should make sense that systolic increases, right? Because that's ventricular contraction. It's the pressure exerted on our arterial walls when our heart contracts. The pressure is going to be greater because there's more blood in our heart now. That Frank-Starling mechanism is going to produce more blood. Diastolic blood pressure is going to remain relatively stable around 80 millimeters mercury, right? So that should also make sense if we start to think about these things, where what is diastolic blood pressure? Well, it is our heart relaxing, okay? So our heart isn't going to relax and change the blood pressure any differently, right? So systolic blood pressure changes acutely with exercises, increases, and diastolic remains relatively stable. So maximum blood pressures for exercise, for systolic, it should be somewhere in that neighborhood of 160 to 220 millimeters mercury. When you get above 220, you start to look into a hypertensive response, and a hypotensive response would be something where there's a failure of your systolic blood pressure to move according to exercise. So maybe it moves a few points up, 10 points up, 15 points up. But if you're exercising at a, if we used RPE, at an RPE of 20 on the Gunnar-Borg scale, right? And your systolic blood pressure only increased by 10 or 15 millimoles mercury, we might consider this a hypotensive response in certain situations. VO2 max, right? VO2 max, incredibly important in this class. So VO2 max is the greatest amount of oxygen that your body can be used, right? The greatest amount of oxygen your body could be used at any given point in time. And why is it important? It is the gold standard. So I wrote this slide, I don't know, 2 years ago now at this point, where it's the gold standard for indicating aerobic fitness. But it is more than that. It is really the gold standard of cardiovascular and your heart health, right? So VO2 max is incredibly important. It's utilized not just in athletes, but in assessing cardiac rehab patients. If they have a VO2 max of like 15, 17, right? This is something that you want to increase through training. Well, how do we assess VO2 max? That's with the Fick equation, or the Fick principle. So VO2 is the volume of oxygen we are consuming, right? So there's VO2 max, which is the most amount of oxygen we can consume. VO2 is the volume of oxygen we are currently consuming, whether it's max or submaximal, and it's measured by Q, your cardiac output, versus the difference in the volume of oxygen between your arteries and veins, right? So what does that mean, right? So we're trying to assess the amount of oxygen we're using, right? We have a certain amount of blood our heart pumps, and within that blood, there's a certain amount of oxygen within arterial blood. Subtract the difference between the amount of oxygen in arterial blood versus the amount of oxygen in venous blood, right? And that's telling us what your body is using in terms of oxygen, right? So what is no longer there is what your body utilized for oxygen. Then you could multiply this by your total cardiac output, right? And that gives you your VO2. Right, I already said it's how much we're using. How might this change with training? So this is something that's a little bit definitely more anecdotal, and just, we've had discussions in class why we think this might change, right? But an example, a thing that happens, an adaptation with chronic, so this is a chronic adaptation with training, is that runners tend to become much more efficient. Whether it's an increase in mitochondrial density, capillary density, whatever it is, they become more efficient. Okay, running economy. I would argue that running at the same exercise intensity. So let's start with an untrained person, and we figure out whatever this VO2 is at a certain pace. So whatever their volume of oxygen consumed at 7-minute miles, right? Let's say they go through an 8 to 12 week training protocol. I would argue that 12 weeks later post training, they're probably going to consume less oxygen because of these because of these chronic changes, these chronic adaptations. They are going to be much more efficient with their utilization of oxygen. They're going to be much more efficient with their running strides, much more efficient neuromuscularly, agonist versus antagonist, right? So that's an example of one way we might improve the use of oxygen, trained versus untrained. So at this point, I've talked about VO2 max, but there are other metrics to describe exercise intensity, and a common one is MET, metabolic equivalent of tasks. This is definitely used much more in the clinical world. So within my world, in the applied coaching setting, I have never used METs, right? So I've never told my athletes, go out and exercise for 20 minutes at, I don't know, 3, 4, 6 METs. However, once you get into the clinical world of cardiac rehab, METs are important to at the very least know. For the purposes of this class, where we're creating training plans for runners, you're not really going to have to know much else about METs other than that it is one method to prescribe exercise intensity. This is just a chart from some research about the metabolic equivalent of tasks of various jobs. Again, not very important for us. All right, now we're talking about blood flow. So we talked a little bit about blood pressure earlier. Now we're talking about the peripheral resistance, which is systemic resistance of blood flow through your blood vessels. And our body is uniquely positioned to change this peripheral resistance based on certain circumstances, all right? So we go through periods of vasoconstriction or vasodilation, right? So as resistance increases within our arteries, we vasoconstrict. This is going to decrease the blood flow, right? So our peripheral resistance increases, our blood flow decreases. And because our blood flow decreases, right, what essentially happens is if we look at like an artery, right, it decreases. What's happening is there's still the same essentially amount of blood. The pressure increases. So the pressure against these walls is much greater, right? And that causes an increase in blood pressure, right? So as blood flow decreases, there's an increase of blood pressure. And then conversely, as resistance, peripheral resistance decreases, blood flow increases, which causes a decrease in blood pressure. And this is really vasodilation, right? So the top one is vasoconstriction. The bottom one is vasodilation. And one way, you know, if you guys have taken the resistance training class, or if any of you guys lift weights, one thing to think about vasodilation is think about some pre-workouts, right? What do they say? They all say, oh, it's a vasodilator, right? And that's essentially what they are. And the whole goal of that is to get more blood, right? By increasing your blood flow, by vasodilating, you can get more blood to your working muscles. Now, would you want to take a pre-workout before going on, a 10-mile run? Probably not. In fact, I definitely wouldn't do that. But you guys understand the analogy. What do we need to know? So at rest, 15 to 20% of our blood flow may be directed to our skeletal muscle, which is not a lot, right? But a acute change to exercise is that this might change up to 90%. So up to 90% of our blood flow might actually be redirected towards skeletal muscle with the onset of exercise. All right, so now we're switching over a little bit. We're still talking about some acute changes to exercises, acute responses, I should say, to exercises. But now we're talking a little bit about the lungs. So just a few terms: minute ventilation, right, which is the amount of air breathed per minute, similar to stroke volume, but in terms of air, O2. Tidal volume should be similar to stroke volume in that it's the amount of air inhaled and exhaled, and your tidal volume is going to increase with the onset of exercise, which makes sense, right? Your breaths are going to be deeper as you start to exercise. With an initial increase in minute ventilation due to increased tidal volume, deep breaths, I just said that. So I put your anatomical dead space in here for a very specific reason, right? So your anatomical dead space is when there's really no exchange of air, of O2, right? So there's really nothing going on, right? So your nose, your mouth, your trachea. So the space is essentially useless. Now, obviously it's important because it's transporting it towards our lungs, right? But one thing to consider is when you're out of breath while exercising, right? What's the best way to catch your breath and why? So we can, quote unquote, catch our breath, right, through two ways. You can either, right, take a deeper breath, or you can breathe with a greater frequency, right? So if you think about it, right, if you think about it in terms of anatomical dead space, one reason, and this is just kind of what people say when you're out of breath: take a deep breath, take a deep breath. The obvious answer should be take a deep breath, right? Well, one of the reasons is really because our anatomical dead space. As we go short, quick, shallow breathing, the air is spending more time and it's passing more frequently through our anatomical dead space, so there's less exchange actually taking place. If we could take a deep breath, it is passing our anatomical dead space less frequently, and it is spending less time within our anatomical dead space. So one of the ways to help catch your breath, and one of the reasons behind that, is because anatomical dead space. All right, also another way to prescribe exercise intensities is doing the talk test. And this is something you can use in practical settings. You could just say low intensities where conversation is, you can have a conversation absolutely freely and not worried about it. Then there's something called ventilatory threshold 1. And this is when talking starts to become labored and uncomfortable, right? And you could tell people, this will take a little education and teaching, but go exercise or go run or bike at VT1, ventilatory threshold 1, for 20 minutes. And then finally, ventilatory threshold 2 is when talking becomes extremely hard and isn't really possible. And you could do the same thing, all right? I want you to run at VT2 for 3 minutes. Maybe you program in a fartlek, which has VT2 for 3 minutes, low comfortable talk for 3 minutes, whatever it is, right? So you can actually use the talk test for prescribing exercise intensity as well. We don't need to talk, I don't think, too much about metabolic transport for right now. We will talk about this. So chronic changes. These are the things we reach for. These are the things we want when we are out there training on your bike, swimming, whatever it is, right? And well, what do we want to increase? Well, we want to be able to increase our cardiac output. We want to increase our Q, right? And we do this by having an increased stroke volume, a more powerful heart. We do want our heart to hypertrophy to an extent. Other increases are increased capillarization. I think I butchered that word. And we want increased mitochondrial density, right? Mitochondria, the powerhouse of the cell, where, after talking bioenergetics, we should clearly understand that the Krebs cycle and electron transport train take place within the mitochondria in addition to beta oxidation. So we need an increased mitochondrial density, right? Now, what do we want to decrease? Well, we want a decrease in our heart rate, right? Our resting heart rate or our exercising heart rate. So if I'm sitting here, my resting heart rate maybe is 70, 75 beats per minute. Through training, I'd like to see that get down to 60 beats per minute. That's a good sign of fitness. And then an even better sign of fitness is lowering your exercising heart rate. So and I use this all the time with people, if your exercising heart rate at, let's say, a 10-minute mile, right? You do 10-minute mile pace for 30 minutes, and your average heart rate is 155 beats per minute. You train for 4 weeks, 6 weeks. You go on the exact same run in the exact same temperature and the exact same paces, and all of a sudden your resting heart rate went from 155, I think that's what I said, 155, and now is 145. That is an indicator that you are more fit. You are absolutely more fit. You were able to exercise at the same intensity, but with a much lower average heart rate, right? So we want to decrease in both resting and exercising heart rate. Power, this is a typo that's been in here for 2 years and I keep forgetting so ignore power. Body fat, we absolutely want to decrease in body fat. Increasing your strength to fat ratio, so your relative strength, is very important, and decreasing body fat is helpful. The bottom line is, for most of my novice athletes or novice runners, and this is probably 95% of people, the best way for them to actually get faster is lose some body fat. It's the absolute bottom line. Now, I don't just straight up tell them, okay, well, you're fat. Of course, I would never say that as a coach, but I would say sometimes, okay, well, what do you currently weigh? It might be a good idea. It's in the off season to get you down to, like, quote unquote racing weight, something along those lines. And of course, this depends on your population, where I would never, I don't discuss this at all with high school athletes, male or female. But when you're working with adults, it's absolutely something to discuss. Resting blood pressure for sure. Lowering your so resting blood pressure and exercise-related blood pressure as well. That kind of just correlates nicely with heart rate. Bradycardia, but bradycardia, right? The slowing, the extreme slow lowering of your heart rate. With bradycardia, is it good or bad? There are some instances where if your heart rate slows down, your resting heart rate becomes so slow and so low, where maybe it starts to become 37 beats per minute, 35 beats per minute, or lower than that, right? This could throw off the signal, right? So your SA node, right, which is what sends the electrical signal for your heart, right? This could throw off that signal, and there have been some instances where in some cases, very rare, that having too low of a resting heart rate is actually a bad thing. And this has happened with endurance athletes. It's rare, but again, as a coach, something to be mindful of. If you see somebody's resting heart rate consistently below 40, and if you ever see it consistently drop below 35, it's just something to be mindful of, but it is rare. In my opinion, there happens to be much more cardiovascular changes than respiratory changes in terms of chronic adaptations. All right, and then lastly, some things that we didn't really discuss and we don't really get into. I think Jack Daniels ended up talking about it in his text a little bit, are other changes. Well, increased neuromuscular efficiency, right? Improved contractions between your synergist and your antagonist, or should we say agonist and antagonist muscles, where your quads are contracting at the right moment, your hamstrings are relaxing, and vice versa, because that happens during a running stride. Reduced cost of exercise. I've essentially already covered this by talking about, talking about how exercising at a certain intensity costs you 155 beats per minute, and then costs you 145 beats per minute. This is reducing the cost of exercise. Improving the onset of blood lactate accumulation. Right. This is a big one. Right. Essentially, what happens is there's a certain critical point where lactate really accumulates within the blood, and this, because of a lowering of your blood pH, will start to affect muscular contractions. And because that's affected, all of a sudden we cannot produce as much force, and this is one of the mechanisms behind fatigue, right? So how do we improve this? What actually changes? Well, our fiber types can actually change, right? We can shift from type 2A or 2X fiber, right, to a type 1, to a more fatigue resistant type 2AX fiber, I believe that is. Don't quote me, I forget now off the top of my head. And because of this fiber type change, we reduce the production of lactic acid, right? We can have an improved hormone response, right? One adaptation to chronic training is an upregulation of hormone-sensitive lipase, right? And what does hormone-sensitive lipase do? It helps you oxidize fat, right? So by going through training, we've got more HSL, lactic acid buffering, and then the HSL, right? So the hormone-sensitive lipase, because that's upregulated and we're burning or oxidizing more fat, another change is that this leads to actual glycogen sparing. So you actually save your glycogen, your glucose, to be utilized later on when it is actually needed. Maybe when you're climbing up a hill, or more importantly, at the end of a race, when you have to go for a sprint finish, right? There's more glycogen at that higher exercise intensity, and you can utilize it at the end of that race. All right, that is it for today. Hopefully this was helpful in understanding both acute and chronic adaptations.